to have this webinar in conjunction with the Mediterranean Association of Neurological Surgeons, the MANS. And I will, of course, thanks Professor Di Rocco for accepting the invitation, in spite of the fact that he is in holiday. And also the panelists. Unfortunately, one of our panelists could not join us today, Professor Ashuri. He has a serious personal problem. And we have two other panelists, Professor Mohammed El-Baltaghi from Egypt and Professor Abdelmajid Miliani from Algeria, and myself. So I will just introduce, before introducing Professor Di Rocco, I will introduce our panelists. Professor El-Baltaghi is professor in neurological surgery at Cairo University. He's chief neurosurgeon of the Children's Cancer Hospital in Egypt, well-known hospital dealing with a lot of cases of brain tumors in children. He was fellow of pediatric neurosurgery at Boston Children's Hospital, Harvard University, and also fellow of vascular neurosurgery, Frankfurt Main University. He is currently the liaison committee co-chair of ISPN, membership committee chair of International Federation of Neuroendoscopy, and secretary of the African Pediatric Neuro-Oncology Society, which is a very young society, and he has the idea to create this society, and I hope that we can do with him a lot of things in the field of pediatric neuro-oncology in Africa. Professor Majid Miliani is also a professor in neurosurgery. He's working at the specialized hospital in neurosurgery in Scherchen, which is a very beautiful town at 80 kilometers from Algiers on the Mediterranean Sea. He's doing a great job. He's dealing with adults and pediatric, but dealing a lot with cases of pediatry, mainly craniosynostosis and also tumors. He was a fellow at Necker Hospital in the Department of Neurosurgery, and he's also dealing with spine surgery. He's one of the neurosurgeon who deal with the most cases of pediatric in Algeria. So thank you to you. And I would like to introduce our guest speaker, Professor Di Rocco, who is well known everywhere in the world in neurosurgery. He is director of the pediatric neurosurgery in INI Hanover. He was former chairman of Institute of Neurosurgery at the Catholic University Medical School of Rome. He is currently the editor-in-chief of Child's Nervous System, which is the official review of the ISPN. He was the past president of ISPN and founded with Professor Schooks the postgraduate course of pediatric neurosurgery, which is now organized by the ISPN and which is existing since 30 years. He is also the chairman of Hydrocephalus Task Force of WFNS and the chairman of Education Committee of the Mediterranean Association of Neurological Surgeons. He has written more than 400 articles and contribute to more than 70 chapters in books. And so I will say to him, thank you again, Professor Di Rocco. And he will talk today about the problems of craniopharyngioma in pediatric population. And everybody knows how is challenging this pathology in our young patients. So Ezio, please, it's to you.
Thank you, Suad, and it's an honor, and I'm happy that Mohamed is here because he's one of the most experts in treating craniopharyngioma. So it will be a nice discussion. I hope he agrees. But okay, now the reason when you asked me to decide, I thought that this is still a hot topic because every time the pediatric neurosurgeon is in some adult congress, they say that we are not so aggressive because they are able to remove the tumor completely without any complication, while we are so worrying about complication to discuss whether the complete removal should be our goal in all the cases. Okay, what we know about craniopharyngioma is that with the passing of the time, we had an increasing ability to remove the craniopharyngioma completely. And we are able to do this. At the same time, we know that the mortality decreased considerably. So apparently, we have not problems to face because we are able to operate and we don't have a mortality. But even though a plateau has been apparently reached, as most of these children survive, some of them are long-term survivors, we have to ask ourselves which is the quality of the life. Often, when you speak about craniopharyngioma, the terms benign tumor is used, and I'm not sure that we can consider this a benign tumor. We know that it's rare, on this we agree. We agree also in the location of this tumor that is really in the proximity of delicate structures, vascular and neurological, with a problem in for the vision, problem from the endocrinal functions, and for, as I said, for the vascular circulations. So the first option that we have, you can see here what the student nowadays read on the Greenbergs. You can see that the mortality is around 10% for the surgical excision, which is seems high, but actually it is true. And also is a little more pessimistic about the survival, because you can see that he says about 55% minimum in the 5 years, which we are used to consider a little more optimistic, a higher survival rates. Can you hear? Is okay? Hello?
Yes, Ezio, continue.
Yes, okay.
We can hear you very well.
Tell me, because I'm not confident in my technical ability. So first of all, my first question is if we were to speak about one type, one tumor, craniopharyngioma, or actually are different tumors under the same umbrella name, because they are so different in patient to patients that really you wonder if it is just one tumor. And this could explain a lot of controversies about the ability to remove or not to remove the tumor. And this different presentation has been investigated especially for the location of the tumor. So there are a lot of studies to try to understand whether the location could correspond to a more easy or more difficult removal of this tumor, to a more easy recurrence, or to a more easy complication. You can see here an example by Professor Chu, and you can see that he made a classification in 5, but actually in 7, 8 subtypes according to the location, suggesting according to the location a different surgical approach. But it's nice to have this type of a complication, but I think that it's not easy to apply this complication in everyday life. So we can say that a lot of children can survive at 10 years, nowadays at 10 years from the operation, almost 90%. And we also know that this variant that is frequent in children, the adamantinomatous variant, which has calcifications and a more frequent recurrence. This also can explain why the pediatric neurosurgeon is a little more cautious than the adult neurosurgeon. Another variant we have in children that make us a little cautious is the frequent presence of gerant forms of the craniopharyngioma. About 10% of the craniopharyngioma are very, very large in children, so to produce hydrocephalus. I think that the real best treatment, and I think you agree, is not established yet. So why is it different to have a pediatric tumor and an adult tumor? In this is an adult tumor, is a prechiasmatic, so you see a chiasma, the tumor, and you have this possibility to see the tumor in front of the chiasma and to remove the tumor from this large window. In children, the retrochiasmatic position is more common, and so the approach in a prechiasmatic is relatively smaller. Often you don't see even the tumor, and you have to go to the chiasma and to the optic nerve and the carotid artery to try to remove the tumor, which makes things more difficult. So when this is a different surgical approach, surgical window, makes already the things different. So in adult, you can remove the tumor from here, you can have an easy access to the tumor. In children, not. And it's not just to say, why does not work? But, okay. I tried to several times before. Okay, there was a big block of the calcium inside the third ventricle, and in the third ventricle to the lamina terminale, you have to manipulate, you have to make more retraction, so you can see that after operation you can have more damage than usual. And this explains the calcium is not smooth, so you can see that you can make some damage in the optical nerve, especially to the adventitia of the artery when you are working through the optic nerve and the carotid. And this, or you have to remove a bigger portion of the calcium walls that leads to this kind of a complication that is to the formation of this pseudo aneurysm. I never saw one of these aneurysms to bleed, but it's not very nice to see when you have the conditions as a large tumor, which makes some difficulties, extra difficulties in removing, because here, especially in the first years of life, this big tumor you can remove, and then you have subdural effusion to take place of this huge cyst, and you can have microhemorrhage due to the kind of atrophy on the site in which you approach the tumor, in spite of a total removal of the tumor. What we would like to have is this, to remove the tumor and to have preservation of the hypothalamus. But in most of the cases, we remove the tumor and we have this kind of results. This is the most common post operative control. And why we have this damage? Because does, in my opinion, does not exist a real cleavage plane between the tumor and the demonstration of a craniopharyngioma invading the hypothalamus with this digitation, with this kind of extension inside the hypothalamus. You can see here in an autoptic study, the same. And also recent studies show that there are some genetic common characteristics between craniopharyngioma and other malignant epithelial neoplasms. So there is an ability of a craniopharyngioma, at least some craniopharyngioma, to infiltrate, to grow inside the nervous tissue. So we know nowadays that we can remove the tumor in 90% of the cases according to what we feel. Let us to be realistic, is probably a realistic figure. So we can remove this tumor. But after this removal, in 90% of the cases, we can have some kind of a hypopituitarism and a diabetes insipidus. And if we are not lucky, we can have a hypothalamic damage, deficit in memory, some lethargy, and what is even more frightening is this modification in the habit of food. But even if you don't have changes in the food intake habit, you have the different effect of the food leading to obesity in some of these children. See, this was an old study done by Schooks, investigated more than 500 children from the literature, and before the operation, there were all this deficit hormonal. You have to think this HTH, these are all the type of hormones, thyroid and so on. And after the operation, what happened? There was an increase in deficit in all the cases. So this is really obvious and cannot be denied. This is, let's say, about 10-15 years ago. This was the situation, and I agree this is a possibility to remove the tumor, but with a surgical morbidity quite high, a perioperative mortality not so low, and then increasing in the first 1 or 2 months of the life, deficit in a very high percentage of the cases, visual deficit, high percentage of the cases, and this kind of result, this obesity, which is very difficult to treat. So the question is, it is worth to remove the tumor totally, having all this complication? The response would be yes, if we can have complications not so important, but and especially if a total removal would mean no recurrence. But let's see these patients. We remove the tumor.
Stop it.
Remove totally. You can see there is some kind of problem in visual and obesity. But after 6 years, we have a recurrence, and then we had to operate again. And so this is the results, total removal, not excluding a possible recurrence, and having this kind of a complication. So in the same time, in the same years, there were the first report of a radiologist with radio surgery, and they were showing this kind of results. The take into account the high mortality of the surgery, high morbidity, high incidence of hypothalamic damage and visual deterioration, they started to suggest the so-called, let's say, minimal approach, combined approach. That is, the goal of operation should be only to decompress the optical nerve and the optic chiasm to control the hydrocephalus. So in children, it could be done just with aspiration of the cyst, both endoscopically or stereotastically, and then not touching the solid part of the tumor and using radiotherapy. The discussion was still about the need to remove the pituitary stalk, which was thought to be the most common place of the tumor to start. So they were showing this kind of new way that now is routine of administering radiation therapy, very focused on the tumor. We know that we can give it to the optical nerve 8 degree of radiation, not more, but nowadays they are so precise that they can do 2 or 3 times the same dosage on the tumor, and that they can have a very good control without damaging the apophysis and without damaging the optical nerve. So even a very good surgeon like Albright, 20 years ago, 15 years ago, 20 years ago, they started to say that just remove the cystic part, and if there is a tumor less than 3.5 centimeters in diameter, give this kind of a treatment on the tumor, and just in the periphery not overcome the 8 gram. So it's with this kind of a treatment, they start to have several papers that really demonstrated that they could control the craniopharyngioma in this way. Having, in most cases, cystic component, obviously, you know better than me, the first attempt by Excel with some kind of isotope injected in the cyst, and also this therapy with phosphorus, rhenium, yttrium, they could have good results. And then we use a bleumycin that was a little different. Phosphorus, you can see, very old, was the first to be used, and the results is very impressive. Series very small, but some were not so bad, a very good control of the tumor. With rhenium was almost the same, very good results. With yttrium, the same. And so we had, at the end of the last centuries, the demonstration that injecting isotope inside the cyst, we could modulate according to the choice, the length of the wave of the isotope, and this way also the depth of the penetration of the radiation therapy, and to control the tumor. Why they did not use this substance anymore? This is a mystery. There are no reports of a second series. All these authors never publish a second paper on larger series, which is quite surprising, showing this kind of success. All the papers were after 1 year, 2 years of surgery, not longer follow-up. Bleumycin seems to have solved the problem because with the isotope, when the cyst was reduced, the isotope moved, came near the optic nerve, so it could give some damage to the optic nerve or to the hypothalamus. And that bleomycin that was not giving a radiation, and you know, it was an antibiotic that has some antitumoral activity, and especially on squamosal cell carcinoma. So they thought that the epithelial tumors like the craniopharyngioma could respond, and they actually respond could be also treated with this substance. And thus, bleomycin does not cross the blood-brain barrier, had to be injected inside the cyst. Again, there were actually side effects, even severe Korsakoff syndrome, deaths that were occasionally reported due to when there was a leak of bleomycin inside the cerebral parenchyma, and so you had to test injecting some contrast material inside the catheter in the cyst 10-15 days after having put the catheter. But even with this, there were some kind of a complication. So also this kind of substance has some doubt in spite of some enthusiastic paper. And then came interferon. Again, very good results that were claimed in the first paper. The advantage is that it's not toxic to the brain, they say, only mild transient side effect like fatigue, low fever, some weight loss, which suggests that can reach the hypothalamus in some way. So this is an example, a cystic tumor, very young child. We endoscopically we put the catheter inside and we started to inject. And you can see that you can have a response to the anti-interferon very rapidly. About the side effect, we had this case that had this kind of response of the brain without any clinical manifestation. No, the patient did not complain of everything, but we, at this point, even though the cyst was reduced with the disappearance, we prefer to stop the treatment and to proceed to remove the tumor. And we could demonstrate that this interferon has really an effect on the craniopharyngioma. You can see the craniopharyngioma. You can see that it's different from the normal appearance. And when you start to remove, you can see how thick is the wall, it has become. It's no more the subtle, the thin wall of the craniopharyngioma that you can take by forceps to forceps and progressively detach and remove. You have really a kind of solid tumor. You can see a kind of a big capsule that still can be removed, but it's more difficult to remove than a fresh craniopharyngioma. So we know that the interferon is working, which is our approach nowadays. If we have a child that is after the sexual development and is already hypopituitarism but has no other problems, we remove the tumor like we were used to do. We tend to have an aggressive behavior to remove the tumor completely, if possible. But when we have a very young child that still has to grow, still has to develop, like in this patients of 2-year-old, we prefer to put a catheter inside to inject the interferon inside, which is very easy through a reservoir with a very small needle. really the child does not complain very much, and we can try to at least gain some years to have the child to grow, and then to inflict possible hormonal deficit when the child is already grown. And which are the mechanism of the interferon? Probably there are some direct effect on the tumor, because we saw that change the aspect of the tumor. And I also would emphasize this anti-inflammatory effect. I will come later on this aspect. And probably there are other effects because there is an increased apoptotic activity after the injection of this substance. It seems everything easy, but actually there are problems. Some problems are technical and depends on the tumor. And you can see here, in these cases, we try to put the catheter under direct visual control, and this was really more easy to introduce the catheter. In other 10 cases, we did it with endoscopy and neuronavigation. Obviously, it's less invasive than a neurocraniotomy, but in 2 cases, we could not penetrate the cyst. Obviously, you can improve your ability to study the tumor, but also you know that it's sometimes very difficult to say if there is fluid inside the cyst or it's some colloid substance. So it's not really easy to predict in all cases, in spite of modern MR apparatus. This is the first problem we found. Second problem is very difficult to predict the result in the single case. In these 9 cases, when we had one whole cyst only, was relatively easy, but most of some of the craniopharyngiomas at least have a cyst that are pluriloculated. So when you put a catheter, sometime you are not in the most important cyst. And so you can have some that respond, other that progress in the other cysts that are not reaching probably of the substance. And again, also in these cases, we had 2 cases in which we had a failure. So with a tumor that were operated already, and we put the substance at the recurrence of the tumor, again, 2 responder, but 2 technical failure. 1 case because as soon as we remove some fluid, the cyst collapse become very, very difficult to be penetrated again. And in the other case, we found some fluid so dense that was practically very difficult to inject some liquid inside. And the further point is difficult when deciding. Then you have got what you want. That is when you have to stop to inject interferon, when you can consider a reduction of the tumor sufficient to allow easy removal. One is the age of the patients, but sometimes the child started to have some symptoms, some headache, so you have to decide if insisting or to remove the tumor. I say this because this example. This is a tumor with a huge cyst. You can see that it's probably not the best case because it probably is biloculated. We put a catheter, 2 catheters in the 2 cysts endoscopically. We started to introduce the substance. The tumor first, the cyst decreased very, very good. After the second cycle and the third cycle seemed to be stabilized, so we thought that we could continue to control the tumor, but we did not pay to this small tongue of the tumor that was increasing, see? And what was this? Was the tumor that was controlled, whether we inject the interferon, but had this small extension that became, some years later, an intraparenchymal tumor. So no more a tumor in the cisternal space, it's inside the brain, so we had to operate this tumor. We had to leave also another catheter to be sure, and to remove the craniopharyngioma inside the brain is not so easy because maybe it's work. Okay. So in any case, you don't have this sharp difference that you can have in the tumor and the cisterna that you can detach relatively easily. You can see that this is not a real capsule and you excavate, but never you are sure that you had removed completely the tumor. So it's a little more difficult in intraparenchymal craniopharyngioma. But the most difficult part, in my experience, is that we have to decide to be less aggressive. Before the operation, we are not able to remove the tumor, or we are afraid, so we stop the operation and we say, let us have radiotherapy. Because at this time we have a double risk of a complication. And this is very difficult. This is a craniopharyngioma. You can see that this craniopharyngioma seems very adherent to the structures. You can recognize really where are the optic nerve, the chiasma. See, so at this point, you would have said, this is a case for minimal invasive treatment, but actually was one of the best case we had. You can remove the tumor completely, save the pituitary stalk. So for a surgeon to stop the operation during an operation is very difficult. So you have to decide before and discuss a lot with the family. In my personal experience, the family after was a lot more thankful to have their child with the tumor reduced in size, treated with radiotherapy and interferon, rather than a child coming out from the operation without the tumor, with a panpituitarism and all the other problems. So we have to think about. And then we're going to conclude which is the most important risk of this minimal policy, or minimal aggressive policy, is that without saying openly, we give the suggestion to other people that maybe it's better not to be aggressive, that maybe it's as effective to treat the cyst if the tumor is small, to use first radiotherapy, then try to remove. So we decrease the number of the people that are aggressive, so maybe we remove the number of children that they have their tumor removed. We try to compare our children that we treated aggressively in the first years, and then tumor that we try to treat less aggressively, but obviously what we had in the first case, more cases with radical tumor resections and less recurrence. In the second series, more recurrence and less radical removal and less deficit. So was not really a surprising experience. So this is what we have. We have a lot. We can operate with different hands. This tumor, more aggressive, more sweet, but still we don't know which is the best manager of this tumor. Still, the dilemma between radical partial therapies persists. And this is the last point. Our choice is not only technical, depends also by the expectancy of the families, what they want, what they expect, the access they have to the substitute treatment. I remember when I was young, there was Yasserji that came to make a conference in Italy. Every time I was happy to say, I removed the tumor in this Italian child that came to me. I removed it without problem. And he did not have any follow-up of these children. So he did not know the problems that the families had after these total sections with all the deficit that these children had. This is, I told you that I want to speak about this inflammation characteristic. When we did, and we are still doing, the study of the proteomics inside the craniopharyngioma and all different tumors, proteomics is the proteins that are secreted by the tumor in a given moment, and give a lot of information. And what we found that was interesting in this, what we found was this high percentage of alpha defensin. And this alpha defensin are secreted as an anti-inflammatory effect, and they produce an inflammation in the time they are active. So probably one effect of the interferon is to modulate this activity of these substances. And this explains also some reports of the people that just remove the fluid of the craniopharyngioma. At the beginning, they had a very green, dense, green-brown fluid. With time, it became more white, more similar to cerebrospinal fluid, probably because they removed these substances. There is also our president of the months that was used to say that you remove the craniopharyngioma. He did not try to remove it. He make a hole in the upper part, a second hole in the inferior part of the cyst, and that the tumor were controlled. We blamed him a lot, say, oh, it's because he's not able to operate, but actually probably he was right. He had found a good way for some tumors to be controlled without a very aggressive treatment. It's not present, so I will not say this to him. I prefer to criticize him, but he had this experience that was very, very good. So you can see here, for example, how different are the system, the content in proteins of epilocytic astrocytoma and the craniopharyngioma, so non-aggressive cystic tumors. You can see that there are very different proteins inside which can explain the difference in behavior and maybe can suggest different way to treat craniopharyngioma in the future to avoid this kind of results. Okay, fish. Thanks for the attention. Okay. Can you see? I touch. You can see me, or I disappeared. It seems that I disappeared. Okay. Can you listen to me?
Yeah, we can listen.
Yes,
Okay.
yes, I can hear you very well for a nice presentation. Thanks a lot. It was very impressive, as usual.
By the way, I had another slides that is a book of that came in this last week. It's a textbook of a pediatric neurosurgery, and Mohamed has a chapter inside, and it's a book that was edited by Punk and Rutka and myself, which is a very good book, obviously. I hope that you can see in the near future. Okay, sorry.
Thank you, Ezio. Thank you for this outstanding presentation. I think we will begin the discussion. Mohammed, are you hearing me? Mohammed?
Yes.
You are hearing me?
Yeah,
Yes.
yeah, now I can hear you.
So we can begin to the discussion. So do you have comment or question?
Yeah, I just want to, of course, I totally agree with the concept that craniopharyngioma is, there is no generalized management, especially in the children. It should be individualized, like each case should be treated separately by dealing or studying first the MRI, the hormones, the optic apparatus, how it is affected, and the growth of the child and the age. And accordingly, we can then decide. That's preoperative. And always intraoperatively, you can still change the decision when it is, as the cases that Professor Di Rocco showed, where you can find the huge calcium that removing it could endanger the optic chiasm or end up in an aneurysm or affect the perforators of the hypothalamus, then it's always useful to leave a small part, and there is usually another line of treatment that could help. And preferably, what is important is the quality of life. That's the most important. What we are dealing with now is the quality of life of these kids who live long. And as we have seen, patients living more than 10 years with some complications. So we need to change our method of treatment. So I usually started in the beginning by removing totally. And after many years seeing the patient having poor quality in terms of hypothalamic affection or school performance, dwarfism. So I changed to a more conservative type of maximum removal and then radiotherapy. I just want to add something, that giving the radiotherapy immediately within the first few months after the surgery is more effective than waiting and giving it late. Because in some cases we assumed total resection and we just followed them up with a very small lesion. Then when we started the radiotherapy lately, the effect was not as good as when we started it early, when we had a residue. I think also that the gamma knife, I had some complications with the gamma knife, like aneurysm and some hormonal affection later on. So I think the conformal radiotherapy would be the choice in case of radiation. For the interferon alpha, I have no experience, but as you have shown nice cases, I think this is also a future of some cystic tumors with very young age, to arrest the growth till the patient has the chance to have good hormonal and rate of growth in his life. For research studies, we have done some beta-catenin studies, and this also works well, that the apparent cases with apparent beta-catenin, we have gave them radiotherapy because they behave more aggressive than those with normal beta-catenin expression. That's what we found in like 50 cases of craniopharyngioma when we studied the beta-catenin in these cases. These are my comments. Yeah.
Beta Caterin so it's like other tumors. The presence can correspond to a major aggressiveness. What do you think? You have a very large experience, and even more important, you got the experience in a short period of time, which is very rare, and to have so many cases in the same period of technical ability and same treatment. So your idea is that is only one type of tumors, or still there are tumors that behave very badly, or that are quite good. So you say only one tumor, or like medulloblastoma one day we will find.
Yes, I think so. It's never one type, because there are some cases which I did total excision. They continue well, but some others, despite total excision, they have recurrence. And on the other hand, those which we did subtotal and radiation, some did well, and some others still have very aggressive recurrence. So for sure, they are not all the same. So adamantinomatous would be a great, the large title, but I believe that there will be more subtitles in this type of craniopharyngioma. They never behave the same.
There was a question from Dr. Urruyo about if I understood, if you have a very young children with a cystic tumor and hydrocephalus, if it could be worth to just aspirate the cyst and then if I understood well.
So I heard if we have a young child with a large cyst
Big
and
tumors,
hydrocephalus,
cystic tumor and hydrocephalus. If to treat just the cystic component for a while to gain time.
yes, we just do endoscopic insertion or aspiration of the cyst and putting an Umaya, and we gain time for his growth and hormones, just following him up till follow up MRIs, and later on, if there is an identified solid part, we can assess. If it is large, then we will go for surgery, and it will be just maximum safe reduction of the size, then radiation, or just we go for radiation after the age of 3 to 4 years.
One problem I think that we should face, because obviously there is a major distribution of cases, and it's very difficult to have a series in like yours in most hospitals in the world. At the same time, we neurosurgeons tended to make the same mistake my generation did. That is, as we are busy, we give the patients after the operation to the pediatricians, to the oncologist, which then become that the pediatricians or the oncologists decide for us. They say, you should operate, you cannot operate, and so on. So I think that probably your young neurosurgeon should start to think to collect you the case, to decide also for the collateral therapy, not to leave the endocrinologist or the oncologist or the pediatrician to decide, blaming us for the complication.
Sure, yeah, sure. We usually, we are having a combined meeting usually with the oncologist and the endocrinologist. They just throw the case for us to start with the surgery and to decide what we are going to do. And even when we say that we left something inside, even if it is not obvious in the MRI, we just insist that there is something and they should start radiation. So more or less, we are the ones who are guiding them now. They don't interfere that much.
I say this because in Germany, there is a pediatric that devotes his life actually to the families with craniopharyngioma. He goes in vacation with them, a lot of this. So he has gained a very high confidence. And then now there is a tendency of the government to have his advice before the operation, to recommend or to really ask that he decide if this tumor can be removed, can be treated with radiosurgery, and to the nose or to the skull. And the family sometimes are confused because obviously a pediatrician does not know the real difficulty in operating. Maybe the tumor is very big, but not appears so difficult to be removed, and vice versa. Small tumor can be very difficult.
Yes,
I think that
totally
we should maintain our presence in the team to decide.
Sure,
Abdel
totally
Majid,
agree.
what you think about this?
Milieni. Micro.
Thank you very much, Mr. De Rocco, for this excellent presentation. I think the question, I agree, and the question is what a complete resection is compatible with good quality of life. Total resection certainly allows a high survival rates, but the long-term quality of life is often impaired. And I think the management of craniopharyngioma deserves more than ever a good reflection of the surgeon. It's not to remove everything, but to ensure a good quality of life. Whatever the management strategy, the main objective must be the control of the definitive cure of these tumors. And the cranial is not a benign tumor in his behavior. To make a total exeris in all the cases is not a good, I think it's not a good reflection. And I think that a proper interpretation of preoperative MRI can assess the degree of hypothalamus involvement or not. And therefore, we can establish a thyroid operative strategy and planning for the removal. It's case per case.
And you said, sorry. For that you have finished.
To personalize the management of craniopharyngioma case for case.
You mentioned the preoperative evaluation of the hypothalamic invasion, and you know about the classification of Saint-Rose, Puget, 1, 2, 3, which is quite simplistic and I think not reliable at all. At my time, there was a classification by Rougerie, that was the best surgeon for craniopharyngioma, and Raimondi. They had 3 types of craniopharyngioma. One easy, that was the intracellular prechiasmatic. One that was difficult, suggesting the need of a good surgeon. And the third type that was considered very difficult and with heralding bad results even in the good hands. So as you can see, 1, 2, 3 was already 50 years ago. And so we did not have a really new classification. And I think, personally, I'm not able to evaluate the infiltration of the hypothalamus on the MR, because what is indicated is the midline. In the midline, there is no hypothalamus. It's on the lateral part. So what we say just with this 1, 2, 3, if the tumor is entering the third ventricle or not, but we cannot say if it is infiltrating the lateral part or in the lateral surface, the hypothalamus. So I don't think that we can rely on this. One is okay. If we have an intracellular tumor, we expect good results. But to say the type 2 is easy on the basis of the MR, I'm not so sure. You, Mohamed?
Yeah, I think that what I have seen is intraoperatively by the endoscope introduction, endoscopic assisted, when I start debulking the opticochiasmatic part and then introduce the endoscope underneath the chiasm to look around and see the attachments to the hypothalamus and the infiltration. So it's, of course, from the radiology, it's completely confusing because many cases we decided it's type 2, and then when we entered inside, it's completely invading, and it was extremely difficult to be removed without pulling on the hypothalamus or injuring it. But introducing the endoscope showed us a lot from the transcranial approach. When we look under the chiasm down inside the third ventricle and around. This is very helpful to identify the invasion of the hypothalamus and to leave this part in alone. But
No,
from
I
the
say-
MRI, I never was able to say that.
From the right. I say this because this classification then introduce a bias in the evaluation of the result. So let's say I have 50 type 2. So theoretically, I should not have a endocrinological complication.
Yes.
And if I have, I'm a bad surgeon, which is not true. So I think that I'm a little discouraged when I say people say type 1, type 2, type 3, because really it's not correct and impedes a real evaluation of the surgical act.
Yeah, I agree with
Suad,
this.
what do you think?
Sorry, I think that before I would like to make a comment, but I will, we will talk about the questions from the chat. And before that, I want to call Professor Georges Salazar, who is with us and who want to ask a question. Are you here? Do you hear me, Professor Salazar? I think no, but
hello, yes,
hello.
I'm here. Thank you for taking my question into account. I was wondering, there are some cases with very big cystic lesions that they recur. They come once after surgery, the cyst comes back. So I am asking, what are the indications to implant an Ommaya reservoir? What's experience with this device?
Is to me the question?
Yes, Professor Dirocco.
Yes, we tend to use nowadays the interferon alpha in the cystic recurrence. And as I said before, we have less rewarding results. I think this tumor that recurs tends to be more aggressive than those that don't recur, obviously. And also when they recur, it's not ever only one cyst, are often a multiloculated cyst or different cysts. So it's very difficult to implant a catheter in all the cystic components. So often the result is that you control the larger one, and at the same time there is another one that grows, then another one. So I think that I tell the family that if we have the recurrence, we started to have a problem, and then maybe it will be very difficult to control. I agree completely with the sense of your question. It's a tumor.
Thank you, Professor.
It's probably more aggressive. It's a bad experience for us.
Thank
so,
you.
Nabila, could you give us the questions of the chat if you have, please?
Now we don't have no more questions.
Nabila.
Yes?
No, we have from Napoleon Ursio, please.
C'est bon. Professor Dirocco has answered to this question.
Okay, thank you. Majid, yes, you want to? Yeah, of course, of
I
course.
have a question for the Dirocco. what's the most appropriate time for radiotherapy after surgery in complete removal? Is it immediate post-operative or delayed after recurrence?
Oh, it's a good question. Mohamed has already said an important things. So the problem is that if we have removed the tumor completely, the MR say that has been completely removed. The child's young, so I will be reluctant to give radiotherapy. But if during surgery I have some doubt to have left a small part of the tumor, or the MR suggests there is a small remnants, even minimal, then I think that if you give radiotherapy just after the operation, or few weeks after operation, is the better time. Then give it later on when there is an obvious recurrence, which is difficult to decide. Because we are proud, we hope that we remove the tumor, we don't have any problem.
Kazadi, I think you want to ask Ezio one question, very important question, yeah?
Yes. Thank you very much. Hi, Ezio.
Ciao, my friend.
Thank you very much, Ezio, for your wonderful presentation, as usual. My question is very simple, is that this debate about the treatment of craniopharyngioma has been going on for years and years. I still remember even when I was a student in medicine, we were hearing these kind of discussions. Now, after your wonderful presentation, what can we advise to young people to take home as a message to take home, considering that the majority of neurosurgeons are working in places where they don't have facilities to correct or treat endocrinological complications? What is your message to take home at present time?
Yes, what I said in the very last slide, the social environment in which you are operate. Obviously, to need of a substitute therapy in a poor country is terrible. You can remove the tumor, but the patient can survive because has diabetes insipidus, has no thyroid hormones, has no. So in all the conference, especially in the past, you were faced with big surgeons that you admire, and all these very important surgeons were used to say, pull, and remove the tumor completely. So when you were in a different context, or you had less experience, you felt badly because you could not remove the tumor completely. But nowadays, we know that technically we can do, but not ever is the right choice. If you are in a place in which you know that you make damage, very big damage, to try to remove it completely, and then you cannot treat the patients because the family cannot afford the medical treatment, then I think you should not be ashamed just to put a catheter inside the cyst and to treat this tumor progressively, slower, just controlling the expansion of the cyst made during radiation therapy, and eventually try to send the patients to a center like the one of Mohamed in Cairo, very, very specialized. But this is important for me, the take-home message. You should not be ashamed to say, I treat the tumor craniopharyngioma partially because I don't want to inflict a damage to the patient, just to show that I am a very good surgeon.
Okay. Thank you so much.
We have Nabila, please. We have questions on the chat, yes? Majid, we just have to answer you. Maybe you will answer you, Mohammed and Professor Diroko, to the questions of the chat.
So there is a question for you, Professor Diroko. Knowing that it's a rare tumor, do young surgeons have to learn to manage their own cases of craniopharyngioma, or do they have to orient them to some specialized centers?
You know, it's a very, very difficult question because one is psychological, because obviously you should have some risk, at least the patients that has a risk, but you should learn to be afraid, learn to face a difficult case. So you want to do. In the other side is no doubt that a child operated in a specialized center, craniopharyngioma, has a lot more chance to come out of the operatory room in a better chance than operate in a center that treat 1 or 2 cases per year, because this is the rate of a normal center, 1 or 2 cases per year. So it's very difficult to gain an experience, a real experience. So I think that would be, if possible, more honest to send craniopharyngioma in your country to a center that has more a better experience, and maybe asking to be present during the operation to try to have an experience not inflicting damage to the patient. It's a real difficult because it's psychological, morally, economically, a lot of factors can influence your decision.
Majid, do you want to make a comment about this question? Micro, please.
Sorry, I have a question.
Now, please, Majid, 2 seconds. Okay. We finished the questions. I thought you have a comment on the question. Okay, thank you. I will return to you. We have also a question from, we have a question from Terak.
Yeah. So his question is, do you think that going translaminar to resect a tumor in the 3rd ventricular is not effective for the type 3?
No, for me, type 3 is not that the tumor is inside the ventricle. Type 3 is the tumor that is adherent to the brain. Inside the 3rd ventricle, often the tumor is not attached to the lateral wall, and the floor, the tumor entering the 3rd ventricle enlarge the floor, make the floor very thin, and the center are displaced laterally. So often, going translaminar, you don't have necessarily problems. So you can remove the tumor without having more damage than usual. Third type tumor is someone that is really attached to the optic nerve, because to the chiasma from below, you cannot see, sharing the vascular supply with the optical pathways and with the hypothalamus, which you can see when you go with the endoscope below the tumor. You can see often vessels going to the tumor and at the same time to the neural structures. So it's not itself the translaminar approach that makes a tumor, let's say, type 3. So really, it was already in Lyon, there were Lapra that started to do a lot of the cases translaminar, and this case went okay. So we have about 40 years follow-up of people that grow up in a good shape. So I think that you can use translaminar approach quite safely.
Thank you, Ezio. Majid?
Sorry, there is last question.
My question.
Majid, après on revient à la question.
My question is about the role of growth hormone in the recurrence of craniopharyngioma after long period of recurrence free with regular follow-up.
Let's say, and I don't want to seem that I speak of myself too much, but I think that the goal is a sharing experience.
Yeah.
One experience from which I I'm really ashamed even now after, let's say, 40 years. And I did the first 19 cases of craniopharyngioma, almost total removal in all cases, and with no recurrence. And so I was very, very proud. I went in Switzerland to have a conference, and I showed these results, celebrating the new technology, the young age. There was an older surgeon, older than me, that says, I would not be so sure of these results. So I was very offended. You say that I'm not saying the truth. No, you are saying the truth. But I would like to listen to you in 10 years. And then, after some years, I started to have a recurrence in these cases. So even the one that started at the beginning, Hoffman, published 2 papers. The first one, no recurrence, you should remove the tumors, and so you will not have recurrence. The same authors, 10 years after, had recurrence in about 12% of the cases. Later on, about 1 out of 4, which is the recurrence rate in all the series. So we know nowadays that if we remove the tumor completely, we can have a recurrence almost ever around 4-6 years after the operation. But as you say, there are cases in which you have recurrence 10 years, 12 years after the operation. So never you can say there will be no recurrence in the single patients. You have to continue to follow the patient, to inform the patients that he can have a recurrence later on. Like he can have some damage from radiation therapy 10 years or 15 years after radiation.
What about for the role of growth hormone in the recurrence?
So I did not take it. No, this was one of the first questions. We give growth hormones, and there was a lot of pressure by the manufacturing house to say that we could give. So they made actually a very large study, about 2,000 cases, and in which they didn't show that there was no effect or recurrence. Personally, I had 2 cases in which we had a recurrence coincident with this therapy, but I think that it was just is that the hormone works on normal receptors, and the tumors should not have receptors responding to the growth hormone. So probably you can give the hormones quite safely.
Thank you very much.
Experience.
We have with us Professor Benbouali, because I must say that in Algeria for interferon, we have only one department who has quite experience, and he has worked on this. He is with us. Maybe he can say in few words his experience with interferon. Benbouali.
Merci. Vous m'entendez là?
Yes, but you have to speak in English.
Thank you, Mr. Dirocco, for your excellent presentation. We have a small experience for craniopharyngioma disease. I want to ask you, what do you think about the last definition about craniopharyngioma? And excuse me for my bad English speaking.
Better than mine.
S'il vous plaît, Professeur Barty. Professor Barty.
No, Professor Benbouali, we have many attendees who speak only English. So please, English.
OK. Non, mais vous allez interpréter, s'il vous plaît.
Alors, Nabila will make the translation.
OK. Je voudrais lui poser la question, qu'est-ce qu'il pense de la dernière définition? Disons que le craniopharyngiome est plus une maladie chronique qu'une tumeur bénigne.
J'ai commencé ma présentation avec ça, en disant qu'on parle de tumeurs bénignes, which is not true.
Maladie chronique qui change complètement notre prise en charge.
I agree completely. It's not a benign tumor. Cannot be a benign tumor. The tumor that recurs in 1 out of 4 patients that makes to make this kind of infiltration that tend to recur 10 years after is not a benign tumor. I agree completely. It's important to explain to the family. So maybe it's the first things we have to say to the family. It's safer for them because they understand. It's safer for us because they know. I agree. It's an important observation.
We have Nabila, the question on the chat, please.
Je voudrais savoir vos résultats avec l'interféron.
Benbouali, les résultats pour l'interféron.
Les résultats bon, nous sommes un centre qui pratiquant la chirurgie mini-invasive des crânio-pharyngiomes depuis plus de 30 ans. Nous avons utilisé depuis les années 88-90 la brachythérapie, l'yttrium et le rhénium essentiellement. Et actuellement, les 5 dernières années, nous avons initié une nouvelle thérapie, la chimiothérapie par interféron alpha, qui ne nous a pas déçus. Le nombre de nos patients reste modeste, 14 patients. Néanmoins, nous avons observé les meilleurs résultats, surtout sur le plan ophtalmologique. Le plan endocrino reste peu encourageant sur les 2 techniques, brachythérapie ou chimiothérapie. Nous restons toujours sceptiques par rapport à une chirurgie à ciel ouvert, aller agresser une lésion qui, même après exérèse totale, peut récidiver 1 an ou 2 ans après. Nous avons même traité des sujets qui ont été opérés à ciel ouvert, ici, dans notre pays ou ailleurs. Donc, voilà notre avis.
And maybe you are the right person to ask you a question I said during the presentation. Je crois que vous êtes la personne plus adaptée pour cette question. Pourquoi pas? Il y a des travaux scientifiques éloignés. On a toujours brachythérapie dans les premières 1 an de ça, des rapports, et pas après 10 ans, 20 ans. I search in the literature papers with brachytherapy with a long follow-up, and I was not able to find. So maybe you can ask this question, why?
Exactly. Yes. The question, please, on the chat, Nabila.
Last question for you, Professor De Rocco. So they're asking is there some tips to predict if the chiasm is prefixed or postfixed to manage preoperatively the tumor resection?
This is with MR. I think you can have a good idea. So it's this is relatively a good radiologist can see the chiasm because as a signal intensity different from the craniopharyngioma, and it's almost ever possible to detect where it is, if it is in front or after, posteriorly to the tumor. You don't agree? Oh, I can't listen to you. What do you think, Mohamed?
Yeah, I agree, of course.
This is a friendship, huh?
Majid, please, I just want to make a comment and you can continue. Just to go in the same way than Kazadi, about the problems, the follow-up of patients, about the endocrinologic problems, and even the teams as a team of Hoffman Wieshoff and people who are defending the gross total resection even in the giant craniopharyngioma are always talking about the problems of endocrinologic side. And what is very important, and you say that in your conclusion, is that the patient, of course, we have conditions inherent to the patient, but of course, socio-economical problems are to be taken in consideration when we are operating these patients, because we have seen many patients who have had good resections and etc., but died from endocrinologic problems because they are living very far from big centers of endocrinology, because parents could not provide a good, and also the neuropsychologic problems. And it is also, we didn't talk, Mohammed, you talk about the quality of life. And unfortunately, what we are, there is a big lack in literature about neuropsychological problems in these children, because they need often special schools, they need help, they need, so I think, and I'm agree with you, Ezio, when you say that the classification of Puget could not be reliable totally, because, and as you said, every patient is a patient. Biologically, genetically, all these things have to be taken in consideration. That's why, of course, as you said, the groups are very important. But really, what I see in Algeria is for all the brain tumors of children, we have the pediatric neuro-oncology group, and everything is okay, because we discuss, we decide with the oncologist what we had to do to resect or to give chemotherapy or radiotherapy. But for craniopharyngioma, really, it's a real problem, because endocrinologists will follow the patient and they will not contact you at the time, and maybe you have to reoperate, but they have choose for you the time, and maybe these patients, I think that for Algeria, we have to work that this craniopharyngioma have to be integrated totally in the pediatric neuro-oncology group. This is my opinion concerning craniopharyngioma. I'm always afraid with young neurosurgeons who are talking always about radical resection. But in these cases, I think that we have to be wise, and we have to balance between what we have to gain in these young patients. And as I said, environment is very important to take in consideration. One question to Mohammed, please. You have talked about beta-catenin. But you will have maybe a big proportion of patients with irradiation cysts. We know that most of the craniopharyngioma are adamantinumatus, and most of them have the mutation. So you will have maybe more and more patients for radiotherapy? I'm asking you.
Yeah, yes. What I concluded from what we studied, that whenever the beta-catenin is apparent, above 5%, then we irradiate, even if it is totally excised.
Okay. Okay.
But we are still studying more now on more patients regarding the beta-catenin and also the mitochondrial behavior of these cells, because we find some changes in the mitochondria of different patients.
Yeah.
So that's what we are doing now, together with the beta-catenin.
Okay. Ezio, please, if I have understand, what you are advising for infants, young babies with cystic tumors, if I can give them, put interferon, it is better to do it and to delay the surgery, even if you showed this very thick capsula, and this is what you advise for the young babies? Huh?
Yeah, I think so. It's because if you operate a child of 2 years, let's say, you have people that cannot grow, even if you give some hormonal replacement, he will not grow. And the growth hormone is necessary not only to grow, it's also necessary for the brain to mature, to become a good brain. So you can have expose the child to a problem of brain maturation up to 4 or 5 years of age. So if you can postpone the surgical treatment, ideally, if you can reach 8, 9, 10 years, you can save the patient's growth. The effect of hormone in maturation, if it is female, is different if it is male. So the hormones also related to the maturation of the person, not only of the sexual. So it's important to have a child that is older to tolerate better the operation. And as this treatment has really very few complications, if it works, it's perfect. But I'm not sure that it's working in all the cases. When the Cavallero that introduced this treatment published a paper, I had a 100% response, which was not in our hands. Then we had a study, a cooperative study with other centers. So the realistic figures is about 50–60% of the cases that are responders. So there are a good percentage that do not respond to the interferon. So we can use, but we cannot be sure that we can participate the operation. But if we can, it's better.
Okay, thank you. Majid, you want to add a comment? Micro. Yes. Micro.
Oui. But the question for Mr. Dirocco, and my question is about patients operated after chemo or radiotherapy, and are there any specific difficulty related to that?
No, the difficulty is that you don't have more a capsule that is very flexible. If you have a capsule that is more rigid, and so you can't operate in the usual style that you can try with the 2 forceps to suck the tumor from underneath the chiasma or from the third ventricle. You have a solid tumor, but still can be operated because it's not so very adherent around, but it's you need to be a little more aggressive because the tumor time is a big piece that comes, but still can be operated.
Thank you.
Please, we have Professor Gnen, who is with us. He's the secretary of the Algerian Society, and he's Mr. Parkinson in Algeria, but he's very interesting in craniopharyngioma also. So please.
Thank you, my friend, Dr. Saad. Thank you for Professor Dirocco for this excellent and didactic presentation. The craniopharyngioma is a difficult tumor to manage, and the recurrence is often present. My question is, what is the best treatment currently for the cystic form? Interferon, phosphor, bleomycin, or yttrium? Of course, with less side effect.
The side effect is interferon. Interferon does not damage the structures around, can preserve very well the optical pathways because decrease the pressure in the tumor, does not damage the hypothalamus, and if it goes outside, apparently, I say apparently, does not make damage. All the other, the radioactive, if they go outside of the cyst, or too near to the vital structures or to the optical pathways, they make damage. The length of a penetration is a few micron, and it's varying from yttrium, from rhenium, so, but still there is the possibility to damage the structures around. And after you put the substance in the right place, but in a cystic tumor, this tend to move, can tend not to stay where you want to stay. Sometimes go to depth, to near to the chiasm, sometimes to laterally, near to the hypothalamus. So I think that they have good results in terms of control of growth and apparently quality of life. But as I said before, we don't have papers with a long follow-up. All the papers that I could read were 1-2 years. And after 2 years, all the craniopharyngioma are okay. You don't have a recurrence, everything is okay. So I would see papers 10 years, 20 years after, but I could not find. I don't know why. I also try to ask a paper on invitation to produce this long-term experience, but I could not.
Thank you.
So I cannot tell, but in the immediate interferon is the safest. There's no doubt. No doubt.
You know,
and it's also more easy because to give a radiotherapeutic agent, you need, at least in my country, a lot of permission. You need to have a radiotherapist that take the responsibility. Cannot be done by the neurosurgeon. While interferon can be done by us.
Okay.
So I think also this is important.
Yes.
You know, Ezio, I was always amazing by the papers about brachytherapy, and I was always asking myself why there is very short follow-up. Why we don't have a long follow-up for these techniques. Really, personally, I'm not talking about interferon, but I have never been convinced by these techniques of in situ brachytherapy. We have a question, Nabila. Yes, we have a question, I think.
Yeah. So do we treat in first stage the cyst or the
tumor?
The tissue portion.
Tissue portion.
Did you hear her, Ezio?
Yeah, I heard, but as you said, it depends by case because obviously every time there is according to the experience, because it's a rare tumor, so we tend to be influenced by our own experience. For example, you have a big cyst. The child is young, new, let's say 2 or 3 years of age, arrives with a big cyst. And then you say, oh, it's going to lose vision. We have to do some things. You take the fluid from the cyst, the child becomes blind because you were too fast. Then you have another child who wait next week and they became blind because you decrease the volume of the cyst. So if you had one experience or the other, you will answer to this question in a different way. So the cyst is a good way because it's a good factor because make the diagnosis more early because the mass effect is higher. You can have hydrocephalus, so make a diagnosis earlier than solve the tumor. But pose this problem. If you are too fast, you change it too rapidly the situation. If you do too slow, you can make you have other problems. But I will say that all surgeons will start during the operation to reduce the cyst because this is what allows you to have a room to approach the solid part. You cannot approach the solid part without removing the cyst. So it's logical first to approach the cyst and then the solid part.
Thank you. I'm asking our two panelists if they have a last comment. Micro, please. Mohammed, do you have a last comment?
I think I can agree with issue about treating the cyst and the solid at the same time. That's for the question, the last question. Only one thing, if we have a huge cyst and impending the visual apparatus, or with hydrocephalus that is endangering life, so we go just for endoscopic fenestration, treating the cyst, and on CT basis without MRI, emergency, and then we do an MRI later on to identify the solid very well, because sometimes the cyst is large and the solid is not very obvious to us how big it is. And according to the size later on of the solid, sometimes we just follow up or give radiation, or we go for treating the solid part. That's the only comment which
Thank you.
regarding this part.
Majid, do you
If I
have,
can-
do you have a last comment?
Yeah. I think the morbidity and the mortality after complete surgical resection of craniopharyngioma in children are well documented. But the total surgical excision should remain the goal for craniopharyngioma that do not affect the hypothalamus. Thank you.
If I can add another thing, is historical. When we were young, they will say, pay attention to the fluid of the craniopharyngioma. If it escapes in the brain, you will have a meningitis, a septic meningitis. This now we know is not true at all. When you do endoscopy, the fluid goes out and without any consequence. So again, we should not believe blindly to what is said or what we read or what we hear from people like me too. So it's just to make your experience.
So thank you very much to the, of course, thank you to you, Ezio, for accepting the invitation in spite of the fact that you are on holiday. And it's always a pleasure to listen to you. I'm very happy that this webinar was in conjunction with MANS. Yes, I think this is the first webinar with MANS, I think, Ezio. And also, thank you to our panelists. Thank you to you, Mohammed. I know that you were very busy tonight, but you stay with us, and thank you very much for that.
Thanks for you.
Thank you, Majid. As always, you are here. And thank you to all the participants. I just would like to say to you that we have had today attendance from Iran, India, Mexico, Saudi Arabia, Tanzania, Congo, Philippines, Morocco, Egypt, Belgium, South Africa, Ecuador, and Nigeria. I think it's the first time that we have so many nationalities.
No, it was really a pleasure. It was really a pleasure, and a lot of good questions. It was a pleasure.
Thank you.
Thank you very much.
Thank you very much.
Bravo.
And hope for the next.
Bravo, Ezio. Grazie.
Thank you,
Carlos.
Ezio. Thank you, Suad, and very fruitful the webinar.
Thank you.
Thank you to you. Bye-bye.
Bye-bye, Ezio. Bye-bye.
Ciao, ciao.
Guinan, tu restes avec nous? Il est parti. Nabila. Nabila. Monsieur Ouamou, au revoir. Ah ben Guinan, il est là, ça va. اقعد معنا كي يخلص سامع شيء ورا يوسف